when we talk about trauma-informed care, we're not talking about a trauma-specific intervention. What we're really talking about is really integrating values, principles, policies, procedures, ways of doing work that really are trauma-informed, that take into account, that don't re-traumatize individuals, and that really take into account that most people need safety, that they need to, in order for treatment to really be successful, the services or the individual needs to really be able to have trust with the treatment provider. And also kind of really, and Ruta's going to talk a lot about this, about really meeting a person kind of where they're at in their recovery, and really to allow the person to really communicate what it is that they need. So without further ado, I'm going to introduce a colleague. I've known Ruta for about 20 years. Ruta is going to, let me let you know what the format is going to be. We felt that because we wanted to keep things a little lively today, what we wanted to do is to have a question and answer period, a question and answer format. So after Ruta introduces herself and tells you a little bit about her, or a lot, about her personal experience and what brings her to this work, I will then shift to a question and answer period with interview with Ruta. However, just want, for those of you that are just on your PC, you'll look to your lower right-hand corner. You can ask questions, make comments, and we encourage you to do so in the chat box. The lines are going to be open, so what we really request is that you utilize your telephone, your own telephone's mute, that you not put us on hold, because we don't want to hear your hold music. So without further ado, I'd like to interview Ruta Mazelis. Ruta, take it away.
Thank you so much, Laverne, and welcome everyone. I so admire Laverne's commitment to helping people that she scheduled this for this day, and you have actually arrived, so I am absolutely thrilled. I am Ruta Mazelis, and I still find it funny to try to talk to people I can't see. So I'll ask you to be patient with me, and I'm really grateful Laverne has suggested this question and answer format because I tend to get going on various tangents for quite a while, and I think maybe she can rein me in a good bit. The reason I get talking in all kinds of directions about trauma-informed care is because I think it is the most profoundly healing concept that we have to offer to the people we are serving, and most often to ourselves. And it's just the most greatest proponent of healing that I've come across. And Laverne met me when I had dark brown hair, and I now have silver hair, which I've been told by young people is a really cool in color to have. Before I get started with a little bit more, I want to say I am working from home today, and I have 2 dogs and 3 cats, one of which likes to scream loudly if she's woken up. Another cat's talkative, and I'm hoping my neighbors don't have their dogs out. If you hear crazy barking and meowing, I will do my best to silence them. Please feel free to laugh in the meantime. I'll do the best I can. And one basic logistical issue, Laverne was kind enough to put out 2 pieces of information for you, and there's one section on resources that I realized I put out an older copy of the resources, and under websites, and maybe I hope to be able to explain these resources to you as we go along. It depends on how we do with time and everything like that. Most importantly, at the end of all this, there's my contact information, and all I can say is these are the resources I have found useful for many, many years for various people, whether you're survivors or providers or working in research, all kinds of ways of looking at trauma from a diverse amount of perspectives. That's what's on my resource list. The thing that needed to be corrected was under websites. I am affiliated with the Sidran Institute, and they used to manage a website for me called Healing Self-Injury. And that crashed about 2 years ago, and we decided not to spend a ton of money to rebirth it as part of the whole Sidran Institute. So if any of you are interested, I have a specific website on healing self-injury which is healingselfinjury.com. It's just been birthed. It only has some basics on it. And I put it in the resources because oftentimes when I travel to mental health centers, whether they're inpatient or outpatient, oftentimes it's issues like wanting to hurt self or others, or hearing voices that are really disturbing for people and hard to contextualize through the lens of trauma-informed care. And so I added the resource about that as well. I'll try to be brief. You've got my bio out there too as part of the workshop description. But I can address this topic I've lived long enough to be a provider of mental health and substance abuse services. I myself am a trauma survivor. I've been an advocate for psychiatric and criminal justice reform for as long as it took for my brown hair to become gray, trying to implement the principles that we'll be talking about today and stop the re-traumatizing that often causes people to become lifetime patients. When we start understanding what people have survived and how powerfully strong they are in their survival, it changes our perspective on each other and hopefully even ourselves, and facilitates growth that I think we don't yet understand the limits of. So how's that, Laverne? I didn't wander too far.
Ruta, and thank you. And so as a starting point, Ruta, can you just talk about what are some of the key values and principles of, first of all, what is trauma-informed care from your perspective as opposed to trauma-specific responses? Can you describe that for our audience today?
To me, it's trauma-informed perspective to me. I carry out there with me whether I am working in mental health or addiction clinics, or if I'm going to the grocery store. It's understanding that a significant minority of our population here in the United States and people around the world have survived profoundly overwhelming experiences. And those experiences, when we have experience of trauma, and oftentimes we have a gut sense of what trauma is. You mentioned earlier, and I think it's crucial that we focus on violence and abuse, physical assault, sexual assault. We know 1 out of 3 girls and 1 out of 6 boys in our country will be sexually assaulted by the age of 18. Just that one statistic. And obviously, if anybody read the news today, you know how much, just pay attention to your news feed and see how much you can identify it as being trauma-inducing kinds of events that are happening to people in our country. We've got volcanoes erupting in Hawaii. We've got school shootings. We've got members of our military on this Memorial Day, you know, dying at a higher rate of suicide than dying in combat, all kinds of things. And, you know, in the space of an hour, I can't get into all the different events that are traumatic, but what I ask you to do is consider your own life and the lives of the people you're working with, and think about what kind of traumas do you ask about? Do you have screening tools where you work? And do you look at your own life when you're asking other people about theirs? There are some very basic screening tools available, and I don't know if you're familiar with the ACE study, and Laverne, you can tell me if that should be a further discussion or not. And that addresses many types of trauma. But what I found is, what I ask people to do is just consider this topic as globally as possible. Sometimes we forget to think about what wasn't there for us. Sometimes neglect comes up as a traumatic event, and that's not usually a single event. It's not something that we often talk about or do a lot of research about. And if you sit with people and you say, what was your greatest pain? They'll say, I didn't matter to anybody. Well, that's profoundly traumatic, but it's not usually on most screening tools. So what I have to offer is many of us have experienced, if we live long enough, we'll experience trauma to some degree. The people you find getting labeled with the diagnoses in the DSM, or people coming into addiction treatment facilities and criminal justice system, usually have a whole lot more traumatic experience in their history than those who do not. There are exceptions, but what I propose is that we see our whole behavioral health care system as a place where survivors of trauma who are coping in the various ways that they find successful to survive are coming in. and it is the most common denominator we have of anybody seeking mental health services. And I ask you to consider that. We have men and women receiving services. We have people of all ages and socioeconomic brackets and cultures and gender identity, all those kinds of things. But if you start thinking about it and if you study the literature, what we find out is that trauma is the most common denominator of anybody who walks in through those doors of mental health clinics, psych hospitals, prisons, jails, substance abuse treatment programs. And that's the most hopeful thing I offer you today, if nothing else, is we know people can heal from the repercussions of trauma if they're addressed from that perspective. And therefore, we cannot ever limit anybody's potential for healing, no matter if they're in the backwards of a state hospital or people that we think, oh my gosh, they're at death's door, or I don't understand them, they sure are acting crazy, or they're cutting themselves, or they want whatever those things are that oftentimes make us really worry for people. I can assure you that people have healed from when they've received trauma-informed perspective on themselves and the systems in which we work. I'm babbling, Laverne. How's that?
That's okay. So, Ruta, what are some of the guiding values and principles of trauma-informed care? I know our audience, the folks on the webinar are going to want to know, how do you operationalize trauma-informed care? So if you can just talk about the values and principles, and then we'll move on to more discussion of, well, how do you operationalize it, and how do you get an organization, staff, and other partners to, adopt trauma-informed care principles and values?
First thing I do is, say I go to a community mental health center to do these trainings, and we have a whole day or 2 days or whatever. And the first thing I always do is ask that everybody who works there participate, so we can, together as a group of people, whoever this is, and ultimately hopefully it'll be the people receiving services as well, challenge ourselves to see people differently and not in the traditional matter of what is wrong with you, what are your symptoms, what does your train wreck self look like? How many diagnoses have you had? And if you've worked in the system or been a patient in the system long enough, most people don't end up with one diagnosis. You end up with a whole bunch of them, and they all seem pretty accurate. And you're thinking, oh my God, people are seriously, persistently mentally ill. That's a phrase we use. Depression seems to be considered a lifetime disorder, all those kinds of things. Are you a depressive? Are you a bipolar? Are you a schizophrenic? It's how most of us have been trained to see people coming through the door. The first and most important part of implementing trauma-informed care is to see people as powerful survivors and not as broken, wounded, diseased folks who somehow genetically became unstable and biochemically are brutalized by an illness that doesn't make any sense, because the research shows that's not true. The brains of people who are struggling with things that we know as anxiety, depression, paranoia, all those kinds of things differ from people who don't, but they are the brains of people who've been traumatized. And what we know now in the neuroscience is you can change how your brain operates. You can rewire your brain, and the way to do that is to start understanding why you're struggling so much in the first place. What I will argue with you is, even if you're so depressed you want to die, it makes sense. Anxiety can serve a purpose. So does paranoia, so do obsessions and compulsions, so does self-injury. These are the repercussions of trauma and how people are trying to manage their internal experience of trauma. And that may sound like a far stretch, but it sets the tone for seeing people very differently. And when I start looking at the person coming in who has been brought through those doors because they are struggling and barely surviving, and I say, why are you not dead yet? That's my first question. Because if you start looking into what a person has survived, you'll be just amazed that they're not dead yet. Find people who are, especially peer support specialists, who understand this trauma component, and ask them for their stories, and you'll be blown away by what people have survived. Laverne and I have colleagues with just mind-numbing stories that and they're now people who are absolutely joyful and thriving. I am one of them. So the first and primary thing to do is change how we see people. And that's really hard to contextualize. That's really hard to talk about how do we implement this in steps A through E. But it's just a primary thing that we need to do is change the ground we're walking on and see the people we serve as survivors seeking healing because they're not dead yet, even though they're struggling. And then there are two primary ways of, I teach the principles of trauma-informed care. One comes from the curriculum Risking Connection from the Citron Institute, which is why I joined up with them many years ago. They also put out a manual called Risking Connection that I encourage you to take a look at, especially if you're a clinician, because they really address this in an extensive way. But this whole thick manual can be summed up in one acronym, and it's called Rich Relationships. This is wherever you work in the behavioral healthcare system, I encourage you to consider these four things in rich relationships: respect, information, connection, and hope. And I know that may sound interesting because it's not like, implement 50-minute hour therapy sessions consistently and make this. But when you think about it, respect is part of seeing somebody as a survivor. I honor your strengths. When somebody comes to us in a mental health setting, we're going to understand what's wounding them clearly because that's what's bringing them in the door. It is up to us to start exploring through a strengths-based approach what are that person's strengths and help them see themselves as the survivor that they are, which then will inspire them with the hope that's needed to take risks for healing. Information is critical. I suggest that you have this kind of information on trauma and trauma-informed practices and principles and say, hey, this is what we're trying to incorporate where I work, and you spread that information all around. We are a trauma-informed agency. You may not even know what the heck that means, but when you say it, you're basically saying we get that this is a huge part of the lives of the people that come in the store, and we don't even have to know you have a trauma history because the percentages say, the statistics say, this is who you are when you're walking in these doors with all your suffering, is you are a trauma survivor and you are looking for healing. And that's a huge different shift of information than you have these 4 identified illnesses that we're going to treat separately. This is where it gets really challenging depending on what your previous operating belief is. I was professionally trained in mental health and substance abuse, and I had to unlearn a good bit of what I had been taught. And when I suggest people, especially clinicians, take a look at rethinking how they see people and how they've been taught about what is psychiatric illness and what is actually trauma survival strategies, it gets very, very challenging. So a huge part of implementing trauma-informed care is being able to sit with the discomfort of this information and of being able to see people differently. The ground of trauma is always based in helplessness. Think of all the different traumatic experiences you can think of, and the ground upon which they exist is an experience of helplessness. I was unable to keep myself from being raped, or the hurricane from coming, or I couldn't make my mother love me. Whatever the traumatic experiences are, they are grounded in helplessness. So the primary thing we can do to address that is to provide as many opportunities for empowerment to the people we serve as possible. If you're working in a state hospital, then I encourage you to say, to the person who's never been able to make a decision because they've lived there for 20 years. I was at such a place 2 months ago, and so we started on saying, would you like red or green Jell-O today? Give somebody a choice. As simple as that, wherever they're at. And if the person can't decide, you can say, would you like both? And then they can have another option to decide. And you start with wherever the person is at to give them a sense of empowerment and choice and say, I think you're stronger than you know you are, and I see you as a strong person, and let's see where we can go from here. And so trauma-informed care says we work together with the clients to implement a treatment plan. we never just, this is what you need to do. And how can we partner with people with our understanding of this trauma piece to help them as they go on their journeys of healing. The other thing primarily that trauma does besides is grounded in helplessness is trauma disconnects people from themselves and from other people and from life in general. Think about that. And think about the people you serve. How connected are they? How aware are they even of their own selves? How well are they connecting with others? What is their life belief system? That gets brutalized by trauma. So the other primary thing to do besides looking for empowerment is to look for every opportunity to connect with someone in whatever ways possible. And that can be as subtle as looking at how people have options for seating. If you work with a lot of sexual abuse survivors, you need to have a lot of chairs whose backs are to the wall, because that's where sexual abuse survivors often feel safe, is where they can see everything in front of them. Little things like that. How do you connect? How do you look somebody in the eye? If that's just a normal thing, to you, that's okay. But if you're a psych patient and most people are afraid of you, you don't get looked at in the eye. Little things. So it's primarily looking at how do we continuously provide people empowerment experiences and opportunities for connection regardless of where they're at. How's that?
Thanks, Ruta. You made reference to sort of four kind of core values and principles, and so you said respect, information, connection, and hope. So can you talk somewhat about how an organization, because all of these are assisted outpatient treatment programs, and we have representatives from the programs themselves as well as clinicians, peers that are on the line. I'm sure that people are very interested in kind of understanding, getting a greater understanding of what these principles are. So can you talk about first respect? What does respect mean within the context of trauma-informed care as a value?
I think it means really seeing the person, even though they themselves may not, seeing them as much more powerful than they are in terms of, I respect also that whatever your struggles are, whether it's anxiety or panic attacks or self-injury, that, yeah, it may look like crazy, but it's called crazy with the purpose. That's basically how I teach it.
Okay. Someone's put us on hold.
Yep.
Okay, they remembered to take it off. Okay.
It's always the same kind of music.
You have the right to choose which ER you're taken to? That's right.
Okay.
If you're being taken to the ER by ambulance, ask them to take you to Memorial
We may
Medical
be able to
Center.
use this as an example.
Faster wait time.
Yeah,
Average is less than
please
20 minutes to
take
be
your-
initially seen by a medical professional and an experienced, compassionate staff of specially trained nurses and physicians. We hope you never
Oh,
have
boy.
in the ER. But if
That's
you do,
okay.
tell them to take me to Memorial.
Okay.
Okay, so if we were being taken to Memorial.
Yeah. Thank you.
Oh, boy.
That's okay.
If you're
We'll
having
try to get through it. I've
orthopedic
communicated
there's no
via
better team to
chat.
choose than Memorial
So I'm
Bone
not
Joint
quite
Center.
sure.
Dr.
Yeah.
Robert Schwartz is the leading
And I want
surgeon
to
in knee
apologize
and
to
hip
everybody.
replacement.
Okay, let's hope that they...
I think that may have done it.
Okay.
Okay.
All right. So, and so just give an example around what can an organization do to create an environment of respect. What sort of activities? What sort of training? Particularly for staff and peer staff. You can do to really integrate respect as a part of the work that you do.
I'll give you an example. Maybe that'll be the best.
Right.
Because respect is an attitudinal thing, and it's just the way we see people that we're serving, not as broken or wounded, but as potentially not understanding how powerful they are and their potential. And I think environment is huge. How you address people, how you contextualize where you work. For example, if you're at the, okay, buddy, go. If I walk into your agency or your drop-in center, How does it make me feel when I come through the door? Go back through your front doors, or bring somebody who hasn't been there before to say, where's the comfort in this? Where's the information about this? Is there a proclamation that we are a center committed to trauma-informed care and excellence? We are serving people who are survivors of trauma, who have psychiatric labels and or substance abuse issues. And how do we treat the people coming in? Are you the prized guest? Every client coming in should be the prized guest instead of, oh boy, sit in the row of chairs over there. I went on site visits to many places, and it's interesting because I have no idea where folks work or what it's like, but you get a good sense of it. I went to a domestic violence substance abuse program for women and their children and in Joplin, Missouri, and we walked in, and this place barely had any money. But the receptionist was very close. She was sitting behind an old desk, and she stood up and she said, come on in, and have a seat. And there were couches and chairs and corners and lamps, and there was kids' art all over the walls. And she said, help yourself to some coffee. And there's a coffee pot and a selection of mugs and all those kinds of things. And we immediately felt warm, right? You're walking into a friend's house. It's a safe place to go, especially if you're hurting. What would you want if you were hurting, if you were anxious or depressed or hearing voices or self-injuring or wanting to die? What kind of place would you want to walk into? What kind of office? What kind of building? We went from that trip immediately to a place, another agency further out west, and it was a program with the same exact services, but we walked into linoleum tile with a woman behind bulletproof glass who wouldn't look at us. And we were the trainers, so that was interesting. So what's the client feel like? Because she was overwhelmed with work. And she said, just have a seat in the chairs. And we were then brought into a conference room, and there were 4 paintings on the walls, one on each wall of that conference room. And as I looked around during the day that we sat there, 2 of the paintings were exactly the same. It must have been a buy one, get one kind of thing. And we got our cups of coffee in our styrofoam cups, and it just was a completely different experience. And that's why I talk about consider your environments. Whatever you work, however you can do to bring comfort to your environment. Where would you like to go if you were hurting? What would you want it to be like? Our colleague Raul Alvarez, who reduced restraint and seclusion throughout the state of Indiana in his psychiatric facilities, said, it's amazing what the offer of something to eat or drink can do to provide comfort to people. Having a choice of seating, saying, we are here to provide services for you. We have a lot of options of various things that we hope will be useful to you. In the meantime, we see you as somebody really valuable. And it sounds really goofy, so I ask you to go back into your agencies, or those of you who've experienced services, think about that journey yourself. What were the things and how were you treated, those kinds of things that were either healing or more wounding to you, and you'll have the answer. I think we all know when we feel respected. And it's not necessarily in the words we're told, because you can also just tell when somebody doesn't really mean it, and I have to say this to you. But if you change your perspective on how you see the person, not as broken or diseased, but as a strong survivor, because they're not dead yet, that embodies that whole idea of respect as it is. But I think the environment is more important than I used to think. You can pretty much heal anywhere, but it's a lot easier to do it in a place that depicts something that says comfort.
Yeah, and Ruta, I just wanted to give some examples in the work that I do. I think one of the things that I think is really helpful is to refer to the people you provide services to as Mr. or Mrs. or Ms. And
yes.
it really helpful how they would like to be referred to, because often, referring to someone as, hey, by their first name, it really is, particularly in many cultures, it's considered disrespectful. But it also
Absolutely.
kind of immediately sets up a dynamic between us and them, that, there's people who are Mr. and Mrs. and Ms. and people who are not. So that's one practical suggestion that I have. And one of the other things that I've seen, Ruta, and I don't know whether you've seen this as well, is that there's often in many settings, when you walk in, there's a clear discrepancy or disparity between where the staff may eat lunch or where the staff sits or has access to, and where the consumers that you're providing services to.
Absolutely.
And these are things that, we as Ruta said, survivors, we take up on that, and really internalize that somehow I'm not valuable and somehow I don't matter. And also it kind of creates, I wouldn't say a hierarchy, but it does make folks, kind of create really differences between, people where you don't really need, where really differences don't need to exist, or you have settings that, as Ruta said, no one paid attention that there were two different pitches, the two pitches were the same. So it's really about being very, very intentional about, the environment you work in. And one of the things, two things I wanted to add, is that the other thing is really important is that you ask the people that you work with, the consumers and their family members, about what would make this a place of healing. Yeah. And they often will have very, very great ideas because they've thought about it. They may be doing things at home that they can bring to you, and suggest that you may want to incorporate some of the things in your office environment.
And especially when culture is not being considered previously, how do you say who is welcome here?
Yeah.
And the people who can best tell you who is welcome here are the people who are coming for services. Right. And Laverne, I absolutely concur with you. We did a little bit of work. I taught corrections officers in a prison a little bit about this, and they decided to refer to the people who are inmates saying, "Sir, good morning, sir," mm-hmm. or by name instead of by number, or just saying inmate. And they just had an enormous reduction of violence just from that, because the people who were seen as, evil and bad, the inmate, felt respected by the corrections officer, and there was no other change implemented beyond just how we taught the corrections officers to see the folks that, they were responsible to instead of for. And the safety for both the inmates and the corrections officers increased remarkably with that simple little intervention, because this sounds all kinds of fairy tale stuff, but when you actually start implementing these little changes, like you're saying, there can be a massive change.
Mm-hmm. Yeah, and it's also it's getting folks involved, consumers and family members, really increasing their stake in what services you're providing and where they're going, and their family members and others are really visiting every week or every other day. So it's really kind of really asking folks, what you could do to make the environment much more welcoming and safe. And then what I've seen, and Ruta, I don't know whether you've seen this, really having that as a project of really getting people really an opportunity in many ways to express themselves and to create an environment that they feel is safe. And Ruta's talked about culture a bit, and I just wanted to bring up an example. I do a lot of work in Hawaii, and we're going to, make sure that we kind of not wrap up, but kind of move ahead a little quicker. But I do a lot of work in Hawaii, and in Hawaii, the vast majority, they really have a domestic violence challenge, and a lot of the women in the prison are Samoan. They're from Samoa, and as well as from some of the other islands of Hawaii. And the warden was saying, there was a lot of, the vast majority of the women had been diagnosed with a mental illness, and were all trauma survivors. And he asked them, he said, what in your culture is healing? And so the women, the Native Hawaiian women said, it's the hula. So I don't know about you all, but when I watch Hawaii Five-0 or old Hawaii Five-0, I'm like, I don't know how that all, well, I'm just jealous I can't move like that anymore. But, and for those of you that don't know, the hula is a story. It's just not a dance where you're shaking whatever. It's a story. So what he did was integrate hula into the services that he was able to provide to the inmates. And most importantly, the women became the teachers of the hula, and it became really part of a daily routine. The other example that I have is that, in Hawaiian culture, there's the notion of sanctuary, of healing, of forgiveness. And many of the folks that you work with, and I can state this from my professional and personal experience, we are filled with enormous grief, no matter how symptomatic or ill we are. We've had losses, whether it's family members, whether it's, thinking that you were going to go to college and you weren't able to do it, whether it's loss of status in the community, and all those things. And many people, one of the first steps to really healing, and this is a value and principle of trauma-informed care, is giving people an opportunity or a mechanism to forgive themselves.
Yeah.
To understand that, to forgive themselves and to give people hope. And I think that was the fourth principle that Ruta talked about, is to inspire folks to really have hope. Because people, when they enter into your assisted outpatient treatment programs, whether you realize it or not, they're grieving. And none of the systems that touch them have given them the opportunity, number one, to understand what grief is, to express that grief in a way that has meaning to them, but then to help them heal from that grief, to go through all those steps that we know that, from the beginning of grief to acceptance, and really allowing folks within the context of treatment to really go through all of those steps and really heal, or at least reach a point of acceptance. Ruta, I don't know if you have anything else to add?
Yes, but that's exactly what I mean. And it's the most beautiful example, because what we talk about with trauma is called healing. When we talk about traditional biopsychiatry, we talk about symptom reduction, of which usually emotions are frightening to people. We have a system that's usually based on talking and medication to reduce discomfort, and healing from trauma can be profoundly uncomfortable, but when you have the supports and the hope in place, then there are no limits to the healing, and that's the biggest difference. We're not looking to smash somebody's symptoms down for no reason. They are part of a story. And how do you help people tell their story? And I'm obviously a profound advocate of therapy animals. I have horses and dogs and cats, and usually the facilities I work in end up with at least a couple of those later, because what you have is trained listeners and trained empaths when you have animals around, just that. But also promoting the arts and music and all those other ways to express emotion and experience in ways that haven't been available to the person before, because they would have done it if they could. One of my favorite intake questions to ask people is, who were you before you became a mental patient? What mattered to you? I mean, do we know that? You can talk to people who have been institutionalized for years or who've been your client, coming in weekly or monthly for years, and do you know their favorite color or their favorite food? Or what did you want to be when you were 6 years old, when you grew up? Do we know these things about people, or are we just looking at where are you broken and what is your diagnosis? Now, we have to, do that diagnosis, and we have to talk about symptoms and all those kinds of things, but if we add in the humanity of it, that's where we're adding in the trauma survivor. And we can figure out how to help create a healing journey for somebody just with the dancing in that culture. It's profound.
Ruta, I'm going to ask you a question of, when you talk about information as one of the four core principal values and principles of trauma-informed care, what are you talking about? Are you talking about giving information to consumers and their families, staff? Can you elaborate a little bit on that?
I'm talking about the ideal trauma-informed agency, of which there are some, which is really good. Most are not there, and for some this is terribly troubling information, is what I said earlier, is we are not looking at people with illnesses, despite what the biopharmacological complex says we are. We are looking at trauma survivors. That is the biggest piece of information you can get. All these diagnoses that you have and these symptoms that you have make sense. They do exist. This is a real experience. But they exist for a reason. And that's the most crucial piece of information. You may be addicted to heroin and profoundly depressed and homeless, but if I start understanding your life, it will make sense, because people will do anything to cope with the sequelae of trauma. You talk to somebody who's addicted to anything, whether it's drugs or work, and our mental health facilities are filled with providers who are trauma survivors who've achieved in ways that society approves, but they're still in great pain. The workaholic is valued in our culture, but they're in great pain, right? What's addiction about? Addiction is about avoiding pain, because we don't know what to do with our suffering. And if we, through our dance, through our music, through our connection, through our cup of coffee with each other, through our putting this, kids' paintings on the walls, create a place of safety and comfort, we can start understanding our journey and our pain, and therefore we can start healing it. And the information that is crucial is to say you are not simply crazy. You are not bad. You are not broken. You are not a victim. You have not been smitten by all these illnesses that somehow have just knocked you down. This all makes sense. Mm-hmm. As crazy as you appear, you make sense to me, and you make sense to the people around me. And I hope you will make sense to yourself, because I see you as an amazing, strong survivor that can heal. And it's so much more than, we hope to reduce your symptoms over time and have you be able to live independently. Yeah, that's great, but we also don't know how far trauma survivors can go. We don't know what they want. So that information piece is huge.
Mm-hmm. Great.
And it depends, who you're teaching. It's really hard for a lot of psychiatrists to get this unless they're trauma specialists. It's very challenging for institutions and agencies to start implementing this different perspective on people. If you talk to peer support specialists, they're going like, oh, I didn't know about the trauma piece, but yeah, respect, connection, hope, duh, And they understand the power of that. But the information is simply that. The statistics say that the people walking through the doors have one thing in common more than anything else, and they are survivors of trauma. And whether you're doing a depression group or a medication group, or whatever you're doing with people wherever you are, if you can keep that piece of information in your head that this is trauma survivors, and these people don't necessarily possibly see themselves through the light of strength and survival, but I do.
Yep.
And I can extend that information to them.
Thanks, Ruta. And one of the things I really wanted to make sure that we got an opportunity to talk about today is that many of you, with the Assisted Outpatient Treatment programs, is that you're in a physical courtroom, although it may vary. The courtroom may be a room, or it may be an elaborate courtroom. Is to really think about trauma-informed care within the context of the within the context of the courtroom. Even though it's a civil procedure, it's not a criminal one, but it's still a courtroom. And to think about the ways in which people talk to each other, the ways in which the respondent, the person who is or may be subject to the order, is spoken to, how they are, where they sit, whether or not the way the tables are arranged, any number of things, but to really think about, how you can operationalize creating an environment where people can really feel safe, and that they don't necessarily, and that it's not another disempowering or trauma-inducing experience. And we're going to
And in the midst of what is a very helplessness-inducing, therefore trauma re-triggering environment, which is a court experience, you can be an anchor to somebody.
Yeah, yeah. Because I've been in situations where even, and I'm a former prosecutor, so a lot of work. I worked in the Domestic Violence Bureau, and I had victims where, you know, they had agreed to go forward with, you know, the prosecutor, done all the things we want victims to do, but the issue was the sound of the courtroom. You know, that it was noisy. There was clanging of handcuffs and all these things going on. And it was, you know, and what we did was we really took advantage, spoke with the court officers and everything, and really said, you know, this kind of stimulation is really upsetting her or him, and really, and when folks realize what it does, I think what Ruta's saying and what I'm saying is that people are often willing to make changes, but the important thing is to get the information and to really understand what is really trauma, you know, what is really trauma-inducing in the way that you may do the work that you do. But Jackie Sue Griffin has a question for you, Ruta. She says, trauma survivors are used to having their time managed, micromanaged. Can you provide a few examples of how we can become more flexible with time management requirements in the mental health treatment? That's a wonderful question, Jackie. And Ruta, I'm going to turn it over to you, my sister.
Well, it's every which way. I think you're meaning on how you're treating your client, right? Your client's being micromanaged?
So, you know, how can you provide, I mean, I think the question is really, you know, because of the universality of trauma, is really think about some examples about how you can be more flexible with the, you know, time management. Let's see what the question is. Jackie's going to, okay. She's talking about the consumers that she's working with and uses as an example, sometimes if they show up late, they're not seen. So she's saying that, you know, folks may have issues with time management or getting from one place to another, and how can you get the system to be more responsive to that?
Well, this is where you come back to the system with information and you say, yeah, this is an issue, and trauma-informed care isn't punitive, right? And it's meeting somebody with where they're at. It's like you said earlier, Laverne, I have a problem with time management. They may be highly dissociative and lose track of time. They may be afraid. You know, oftentimes people are getting services and they're confused and they're afraid. And when you say this is part of trauma survival and punishing people, if it worked, you know, our clients would be healed in a day because we sure punish them a lot. If you're late, if you don't do this, if you don't take your meds, if you get too loud, those kinds of things. That's the educational piece. But in the midst of it, what I've done with folks, if I was working with somebody and they were being punished because they were late, so therefore they missed out on a service, the way I talk to that person later, and everybody decides how they are with folks, I would say, you know, I really don't like this rule to my client. I say, I don't like this. I miss you. You don't get what you need. We're stuck with this rule for right now, but how do you feel about it? And what you're doing just by acknowledging that, you know, this is uncomfortable to you, I wish this wasn't the rule here, you're providing that person with an opportunity to connect with you, and you're empowering them by saying, what is your opinion? You know, is there anything we can do? Because I really hate seeing you miss these services. I hate this rule. Because when we as facilities, we usually try to control everything, right? We try to control symptoms. We try to control people showing up on time. We try to control how people behave. Control, control, control. And when you try to control somebody, what happens back? Oh, heck no, or otherwise. You know, sometimes the only thing people can do is almost hurt themselves just to not be controlled. That's like my area of expertise is self-injury. And oftentimes I'll get phone calls saying, you know, this person's living in restraints and they're self-injuring worse than ever. And I'll go, well, that makes sense. And they go like, are you kidding me? Are they that sick? I go, no. You've got a trauma survivor whose trigger is helplessness, right? So when you tie somebody down for doing a behavior that they feel is necessary because they're coping with trauma, and you put them in a helpless position, they will cope more and more with how they know how, which is more self-injury. And the more you try to control somebody, the more you trigger helplessness, right? And it's mental health system similar to the criminal justice system. We sometimes think we can punish people into behaving a certain way we want. And trauma-informed says people behave the way they do because it makes sense to them. And the more we can get pliable about this and say, okay, you're not coming on time. What can we do? Do you know what it's about? And even if you can't change the circumstances or the rules, the way you can connect with that person is a healing opportunity in the moment. Does that make sense?
I do think it makes sense, and it's, kind of one of the things that we've learned is that often creating a trauma-informed environment and a trauma-informed system of care doesn't cost any extra money. In fact, it will probably save money in a lot of different ways. And and what it means is basically really looking at and assessing and getting folks involved around what you could do differently to create an environment that is more respectful, that we're informational.
The cost is in the courage to see things differently, for sure. Yeah. And the outcome is amazing.
Mm-hmm. Yeah.
And what you'll have happen in that particular example, usually when somebody is responding to the rules and being controlled and this and that, and people are micromanaged. When I work in a state hospital, I always suggest the staff get institutionalized themselves for a good week or so to understand what it's like to live behind a locked door and have your whole schedule dictated to. Mm-hmm. Because we don't know. Unless I have the benefit of also being a survivor of being institutionalized, so I know what that feels like. If you haven't had that experience, you may not understand, because we really are well-intended. This is for your own good to be on time. And so we don't get it. And we get in this power thing, well, you need to do this because it's good for you. And I've gotten to the point where there was a therapist that mandated a client to go to an empowerment group. And it's like, no, I'm sorry, you can't do that. Mm-hmm. Yeah. You can't force people to empower themselves. You can provide opportunities. So once you take the force and the coercion and the power out of it, everything changes. Mm-hmm. Everything can change. Once I'm not punishing you for being late and I start understanding you, pretty much you're not going to be late anymore because you want to be here.
But the question is, and I think, our listeners may be struggling with a little bit, Ruta, is that, these are assisted outpatient treatment programs where they're implementing outpatient treatment, where indeed some of the if not all, most of the consumers peers that are in the programs are mandated, by the court, that they haven't been able, have been deemed they haven't taken medication or followed the treatment plan, what have you, or safety, risk to themselves or others. And so the question I have is, how do you harmonize kind of that model, which is many communities have opted to implement for good reasons in most cases. But, how can you harmonize that? Because I think a lot of times the disconnect is, well, we can't do trauma-informed care where there's some element of coercion or force involved. So can you talk a little bit about how you can harmonize that?
Yeah, you apply the principles regardless of where you're at. And that sort of system is a lot of coercion, a lot of control. So you start by tweaking, and wherever you are working in the system, if you're working with the clients, you try to provide connection and empowerment. You try to provide information to the people who are dictating how things should be done. Whether if you don't have an administrator that's into trauma-informed care, you're usually sneaking these principles around. But it's basically a way of saying, even in the most controlling, coercive of places, for example, a state hospital where people are still getting tied down repeatedly and forcibly medicated, and they can't, they have to eat with their fingers and all that kind of thing, you can still implement these principles in how you see that person, how you address that person, the options you can try to give them. And what we start, like with the restraint and seclusion stuff, which actually parallels what you're talking about. It's a different kind of restraint, but it's so controlling that you kind of say, I'm sorry, this really sucks. And what we teach is when somebody gets restrained, that's a treatment failure. We are failing these people by coercing them. And if you can keep that mindset even in the midst of it, you can find the cracks where you can start giving people options. And even just saying, this is really challenging. This is so controlling. I am uncomfortable. I wish we didn't have to do it this way to your client. Imagine what that might feel like. But it's a massive amount of risk-taking on everybody involved because sometimes organizations don't understand that, and folks, get chastised for it. So you have to come up with your own ethics, and you have to have your own supports in place in order to do that.
Yeah, one final thing, Ruta, because I don't think we have any questions. Let me open it up to the audience before we close. Are there any questions that folks have of Ruta before we ask Ruta one final question? Okay. Ruta, if you were talking to, policymakers, providers, what's the one thing that someone could do tomorrow to begin integrating values and principles of trauma-informed care into these programs? What's one thing they could do?
I think what I would suggest is everybody sit with themselves at some point this weekend and figure out their own pain and suffering and consider what it was that was helpful and what was hurtful to you on your own life's journey. Whether you've ever been a mental patient or if you've just been a clinic, whatever it was, as a human being, think about the suffering you've experienced and what was helpful and what was hurtful, and the next time you go to work, try to eliminate the hurtful and do what was helpful in your own experience and see if that changes anything for you in how you do your job.
Thanks, Ruta. And just an endpoint is that there are some strategies that organizations will be sending out later next week.
And some of the resources, and I did leave my phone number and email on the resource thing. I know I've been babbling, and I frankly would love to have Laverne around the campfire for about 3 days with all of us, because my hope for this hour is just to get interest and intrigue and excitement about this. That's about all we can do. But, for example, the Sanctuary website is by a psychiatrist who's implemented trauma-informed principles of care and has organizational strategies on how to deal with this and implement this, and Community Connections in D.C. has done that. There are a lot of resources. You don't have to do this from scratch. But this hour has been to hopefully gain your interest, and if I can refer you to other resources, please just get in touch. If I haven't made any sense, it's a reflection of me and not the topic.
Thanks, Ruta. And what we will be doing is sending out some materials that will help you kind of begin, extend beyond what Ruta recommended that you all do over the weekend, and really begin to look at concrete strategies, policies, practices, procedures, hiring practices, environmental, practices, whatever that can.
And I would really suggest, for those of you who are willing, looking at the neurobiology of traumatic experiences and the parallel with psychiatric illness. There is an incredible amount of research and neuroscience behind all this trauma information that is extremely powerful. Yeah. And because I realize this hour has probably felt like airy-fairy, but there's an enormous amount of research to back this up.
Yep. And we'll make sure that that we provide information about the neurobiology, because a lot of it is recently emerging out of some of the work that was done with the ACE study and other work that's really looking at brain chemistry and other kinds of changes that really occur following a traumatic experience. And so we just want to thank you all for spending time with us today. Trauma, as Ruta said, the important thing is to think of trauma universally, and not the exception to the rule.
Right.
To assume that most people that you're coming in contact with in your work have experienced some trauma, and really begin to think about how you can integrate values and principles of trauma-informed care into your programs. But most importantly, because values and principles are cool, but it's really about how you operationalize it. What do you do? Really, what changes in the work that we do and in what our approach is. So we'll provide the additional resources to you Tuesday when we get back. Ruta, thank you very much for your great presentation and really.
I'll be picturing you doing the hula dance.
Well, that's a whole nother story. I tried. But thanks a lot, Ruta. I mean, you've been really one of the leaders in really helping all of us really understand the impact of trauma and how you can really create a trauma-informed environment. We wish you a very wonderful beginning of summer, a very safe holiday, and we look forward to the next time that we're all together. It's an important time for me, and I thoroughly enjoy spending time with all of you, and we really hope that you've gotten something out of today's conversation. Be well, and Ruta, I'll let you end it before we sign off.
Oh, just thank you for listening to the babbling, and if this topic didn't sound interesting, then find another person to teach it to, because it's amazing.
Ruta,
be well, everyone.
Great. Take care, Ruta.
Okay, bye-bye.
The leader has disconnected. The conference will be terminated in 5 minutes.